So just trying to be a little bit provocative, there's evolving information in the literature that suggests that early supportive care and palliative care interventions are associated with better outcomes for patients with disease that's otherwise terminal. And we don't talk about this much in the kidney cancer arena, but clearly in lung cancer, for example, most people, it's suggested that you have an early supportive care / palliative care consultation. Danny, any thoughts about that in terms of how we should be delivering care to our kidney cancer patients who, despite all of our efforts, may very well succumb to their disease?
So definitely, as Brian said, kidney cancer is a spectrum. And so there are patients where kidney cancer is becoming more like a chronic disease. There are some patients where kidney cancer is very active and very progressive. Definitely, we try to involve the supportive care and pain and symptom management group, palliative care group early, especially if people are developing symptoms, to manage their opioids, to manage their symptoms like nausea, and so they actually get involved quite early.
How about at Cleveland Clinic, Brian?
Yeah, we have a very big and strong palliative care department, so I will involve those folks early, not necessarily for every patient, but for the ones Danny talks about that you just know they're kind of in trouble, or maybe they had primary progressive disease to their initial TKI, and obviously those patients have a short survival and it's likely to be rocky.
And Chuck, are you experiencing that in the community as well, where you're getting your palliative care doctors involved early?
Not usually. Problem we have is if you consult palliative care where I am, they usually interpret that as signing off toward hospice and end of therapy.
Yeah, and I think that's one of the great transitions that we need to start to think about, and that is that supportive care, palliative care is not the same as hospice care,
right.
And there's still a lot to offer those patients.
The distinction's blurred.
Jen?
I would say my experience is more like Chuck's, that it is not, they almost will not allow patients with active treatment to be in their program. And so when I'm dealing with a patient, I really want to see 2 points on the curve to see what their pattern of growth is going to be. And if they are progressing quickly, then we start having conversations. But if somebody continues to want treatment, I really have to shop to find a palliative care group
To partner with you.
who would partner with somebody that wants to maintain treatment, and it's a big problem. So I do actually, our group does a lot on our own.
And I think that's oncologists have very much been trained in that space. I think the field is changing, but we have to kind of always revisit partners. I mean, because this is multidisciplinary care. So let's turn to a second patient. And Danny, we'll turn to you first. So this is a 65-year-old male with a history of metastatic kidney cancer. In 2000, the patient underwent a nephrectomy and adrenalectomy. It's a clear cell RCC, 3P deleted. 9 years later, recurrence of lung nodules with biopsy consistent with clear cell RCC, present on the scan for 2 years prior. Let me stop there for a second and just ask everybody, but Danny, you first. Do you always confirm histology at the time of recurrence, if it's years after a nephrectomy, or if it looks abnormal on a CT, you just assume it's kidney cancer?
Yeah, lung nodules can be difficult because the differential diagnosis is large. And I think if the lung nodules happened 3 months after their original diagnosis of kidney cancer, that's more likely to be kidney cancer, and I probably wouldn't biopsy those patients. But for someone with a very long disease-free interval, what if he has lung cancer, or what if he has something else? And so I would biopsy this particular patient because it's been 9 years.
And we'll get into some systemic therapies in a second, but we're getting better at delivering radiation therapy to lungs. Do you talk to your radiation therapy doctors about SBRT to if they have 1 or 2 lung lesions as opposed to starting systemic therapy?
I think if there's a solitary lesion or even 1 or 2 lesions that could be surgically removed, we do talk to our surgeons, because if we can render someone NED, that can afford them a long-term chance of a potential chance at long-term remission. That being said, this is a very special case because he had a long disease-free interval. In people with short disease-free intervals, I'd be hesitant to jump in with surgery right away, because you might deal with this issue here with surgery, but then maybe there's a lot of other disease somewhere else that surprises you later. So I think it depends on the patient that you're dealing with.